Hi, my name is Hannah, and I did my research proposal on treatments for adolescents who have attention deficit hyperactivity disorder. I wanted to specifically focus on the application of behavioral parent training and applied behavioral analysis therapy with children who are aged 6 to 11. For my introduction, I wanted to focus on the alternative treatments of ADHD, so focusing more on therapy or behavioral training instead of the medication route that's typically focused on. And I wanted to see if these types of interventions could have a effective long-term goal instead of the short-term goals that are typically involved, and as well as focusing on parental involvement in the therapy instead of just focusing on a child-centered approach. And my hypothesis was that adolescents with ADHD who are presented with ABA therapy and their guardians are engaged in BPT, the severity and frequency of problem behaviors will decrease quicker than adolescents without guardian engagement through the BPT. So basically, I'm saying that BPT will enhance the effectiveness of ABA therapy. Within my literature review, I wanted to explain ADHD and the past treatments that have been effective in it. So, starting with the first item, ADHD is a common developmental disorder affecting 3 to 5% of American children. It's often characterized by inattention, impulsivity, and hyperactivity, which these symptoms do vary greatly by gender. But if the symptoms are left unmanaged, it can lead to academic, social, and daily life difficulties, which then lead to risky behaviors as the child develops. ADHD is often comorbid with other disorders like oppositional defiant disorder, conduct disorder, or autism spectrum disorder, which have all shown to respond pretty well to ABA therapy. And as we look at the past studies, it has shown that achieving normalized behaviors in children with ADHD is challenging and typically negatively impacts parent-child relationships, which is what BPT has been used as in using the learning principles that the parents learn to reduce problem behaviors and improve that parent-child interaction. So with my study, I wanted to determine if using ABA therapy, which is individualized and uses continuous reinforcement with behavioral parent training to teach parents how to reinforce those positive behaviors, could lead to better outcomes for that child rather than just ABA therapy alone. So integrating BPT with ABA should result in quicker and more substantial decrease in problem behaviors and increase these positive behaviors. Within my methods section, I focused on the inclusion criteria of children aged 6 to 11 years old, a current ADHD diagnosis, so typically within 6 months is current for children, and it needed to be done by a child psychiatry specialist. I also needed an IQ score of 80 or greater, and I was fine with comorbid disorders like oppositional defiant disorder or autism spectrum because those would be fine playing into the ABA therapy aspect. The exclusion criteria would be if there was participation in other psychosocial or pharmacological treatments, either by the parent or the child, or if they couldn't commit to the treatment program sort of thing. And then the recruitment would be through referrals, through other therapy programs or outpatient programs if the parents were looking for a different treatment approach. The sample size would be a target of 60, but assuming there's a dropout rate, it would be 28 per group. I chose 2 measures for BPT and 1 for ABA. So the first one for BPT is the Parenting Stress Index, which is what it sounds. It measures how much stress a parent goes through based on difficulties they face and how their emotions impact that. It has a child and parent subscales to answer. Then there was the ADHD rating scale 5 based on the DSM-5, and I chose a home version so it could be done at the same time through like Qualtrics. And this focuses on the symptomology through inattention, hyperactivity, impulsivity, and that combined aspect, and that's what it tests in the subscales. And then the IBERG Child Behavior Inventory is used for ABA and focuses on the short behavior changes that happen through ABA treatment and sees the frequency and impact of the behavior and how it plays out on the family, and if the child is actually learning anything from the treatment. My procedure section was pretty basic. We have the informed consent, the demographics. The only main thing there was that there is a gender difference of boys being diagnosed more than girls, so there probably would be more boys in this study. The random assignment, which is pretty obvious, and then the purpose of the control of choosing ABA instead of BBT would be to see if there is an effect of ABA at all, sort of focusing on like, we do know that BBT is effective, so having ABA by itself, if we do see a change in that behavior, it would be a difference instead of like, we already know that BPT would change the behavior. So the intervention group would be receiving behavioral parent training and ABA therapy, and the control group would be receiving just ABA therapy. The scoring is pretty intuitive. As scores go up, so does like negative symptomology, the stress, things like that. The first level of this graph shows the range that the scores can go to. The second level shows the minimum scoring and high scoring for like how much this is impacting the individual. So for example, the parenting stress index, a score of less than 62 is pretty normal. And then once you get to 67 and above, that's a severe amount of stress that the parent is undergoing. Same thing through like 11 through 39, and then 51 through 54 of the ADHD, that's the most symptomology, the most amount of negative behaviors that the child is exhibiting. And then through the IBERG, 131 is the clinical cutoff, and then same thing with 15. This one, as the scores get higher, it's even more concerning because they're weighted through the two scales. For my statistical test, I chose the multivariate analysis of variance, so the M-ANOVA, that's focused on my 2 independent variables with my 3 dependent variables over different scoring periods. So there'd be a baseline, a post-intervention, and then a follow-up. And for the ECBI, there would also be multiple tests done throughout the ABA therapy to see if there's any changes in treatment that need to happen. And the purpose is just to see the distinct changes between measures throughout the groups. The main focus of my study is if ABA therapy could be effective in managing ADHD symptoms. We know that BPT is effective in managing symptoms in these children because it teaches them that positive behaviors are reinforced when they're at critical development stages. And ABA therapy does that, which with children who have like autism spectrum disorder through changing reinforcement contingencies. So would the combination of these two treatments be more effective with these children? And would it enhance their outcomes in the future? Like, would it be a short-term sort of thing? Would it be long-term? And how this would affect the children managing their own behavior.